Evening, everyone. My name is Simran Chaudhary, and I welcome you all on behalf of Voice of Healthcare. And it's an honor to be part of today's very important session, Head and Neck Cancer Early Detection, Better Outcomes, organized by Voice of Healthcare and supported by Lupin. Head and neck cancers, though highly treatable when caught early, but continue to be a significant public health challenge due to delays in diagnosis and treatment. Through this session, we aim to drive meaningful conversation around early detection, patient centric solution, and the role of innovation in improving outcomes. And today, we are privileged to have with us a distinguished panel of oncology experts from leading institutions across India who will share their insights, best practices, and perspective on changing the course of the disease through timely intervention. So, let's take a moment and introduce our esteemed speakers. Dr. Arun R. Warrior, Senior Consultant, Medical Oncology at Aster Medicity, Cochin. Good evening, sir. It's an honor to have you with us. Dr. Vamshi Krishna, Director and Head Medical Oncology and Haematology, Institute of Oncology, AIG Hospital, Hyderabad. Welcome to our show, sir. It's an honor to have you. Dr. Ravi T, Senior Consultant, Medical Oncologist at CG Cancer Hospital, Bangalore. Good evening, sir. Thank you so much for joining.
Thank you, same here.
Thank you, sir. Dr. Sivasubramaniam, Consultant Medical Oncology, Narayanaa Hospital, Chennai Hospital. Welcome to our show, sir. Thank you. Dr. Karthikeyan S, Consultant Medical Oncologist at Rai Memorial Hospital, Chennai. Welcome, Dr.
Good
Karthikeyan.
evening, everyone. Thank you.
Good evening, sir. Dr. Vidya Sagar, Consultant Medical and Haemato-Oncology at Medicover Cancer Institute, Visakhapatnam. Welcome, sir.
Thank you. Good evening.
Thank you, sir. Thank you so much. Now it's time to start our conversation. So, without any delay, I would like to start my first question, Dr. Arun. So, how do you counsel patient on the risk of factors of head and neck cancer, particularly lifestyle-related ones, such as tobacco, alcohol, or based on oral hygiene? So, you're on mute.
So if you look at head and neck cancers, the main reason is the use of tobacco. So if you see 10 cancers, almost 8 or 9 will be directly related to the use of tobacco. So we have to stress tobacco, but it is not just smoked tobacco like cigarettes and BDs, but also smokeless like gutkhas or pans. All those things are having an impact on the increase of head and neck cancer. So first thing is to stop smoking. The second risk factor is alcohol. So again, studies have shown that both have got an additive action. That is, the persons who smoke and take alcohol, the risk increases. And again, there is a direct correlation between the exposure of these chemicals and the incidence of cancers. So, someone who smokes heavily, someone who drinks heavily, the risk factors can be as high as 30 to 50 times higher. So while those who are not that heavy users, it can come down. But definitely the risk increases, and more so with the duration and the number of these chemicals exposure that they have. The third thing is about about the oral hygiene maintenance, because particularly some viral infections like HPV virus infections, because of the change in the sexual habits of the persons, may be a reason while these the cancers are going on. So definitely they have to be aware of this. The new generation has to be aware that this exists there, and they have to practice safe sex practices, and also the number of partners. All these things are important. And vaccination in cervical cancers has come up, but in oral cancers it is still debatable. So as of now, we can't vaccinate someone for to reduce the risk of oral cancers, but maybe we'll reach this. I think that covers most of the things.
Thank you so much, sir, for answering that and elaborating this to our audience, because it is very important to understand how all these factors contribute to head and neck cancer. And we believe, yes, tobacco, alcohol is the biggest factors contributing to this. As if we work on a lifestyle, there could be a significant reducing number of cancer rates. Thank you so much for that. My next question is to Dr. Vamshi. So, from your regional perspective, what are some early signs of head and neck cancer that clinicians commonly miss? And how can awareness at the community level be improved to facilitate early referrals?
So that's a good question. Essentially, the early signs would be a small ulcer or any small growth somewhere in the hidden part of the oral cavity. For example, there are people who have a small gum swelling or a gum lesion. In people who have already got poor dentition, sometimes this is not picked up. The referral pattern is very important that you need to do a full examination of the teeth, of the gums, and of the recesses in the mouth because that's where your cancers can stay hidden. While people do go for dental cleaning, it is not a very accepted practice. And sometimes, because of malaligned teeth, because of poor dentition, people actually miss finding out the cancer. So the assumption is that it is all due to a poor bad teeth. Teeth extraction is advised. And we have often seen patients who get the extraction done and then come to us with the diagnosis of a malignancy. So the awareness has to be early that any change in the in the form, any change in the consistency, any change in ulceration, all these are important considerations to look for oral cavity cancer. Regarding other area cancers, usually they will not present very early, but hoarseness of voice, any persistent throat pain, any dysphagia, neck swellings, all these should not be ignored. The major challenge again always is sometimes the people ignore these as minor complaints. We need to overcome the whole stigma of going to a doctor for checkup and ensure that you go for a checkup, and even if all the reports are normal, continue going for checkups whenever required. So the whole oral hygiene and more focus on oral hygiene is important.
I totally agree with you on that because this oral hygiene part we normally neglect, and we don't think that this may cause that serious problem. But it's time to take it very seriously as it can convert into a very dangerous disease, and we should not ignore the signs and symptoms of it, like just you explained. So I think we need to remove that stigma around of going to doctors. So thank you so much for answering that. My question is to Dr. Ravi. Dr. Ravi, are there any national or international screening guidelines for head and neck cancer that you follow in your practice? And how effective are they in identifying patients at risk on?
Yeah, thanks for the question. Unfortunately, there are no national or international screening guidelines for head and neck cancer. Each country and each practitioners have their own way of screening. If you ask in India, what we practice is it's mainly awareness. So creating awareness among first the general practitioners, physicians, the dentists. So that is a very important task which we are following. The other is like what we are doing now, the social media awareness. So going to the general public about uh, one is already we have spoken regarding the habits, awareness, and whenever they develop any symptom, they have to report to the primary physicians or dentists early. So, since there are no strict guidelines or framework which a physician should follow in our country, I think awareness plays a very key important role. It is not only the oncologists, but mainly the general practitioners, the physicians, dentists. I think they play a very important role.
Definitely, sir, and they all play a very important role, and that's how this entire healthcare ecosystem is built to help each and every patient, and they are there to support to treat them on time, so that they can cure that person completely. So thank you so much for answering that. My next question is to Dr. Sivasubramaniam. So, are you seeing any efforts at the institution level to implement structured screening protocols for high risk population, and what impact has that done on early detection? So, can you hear me?
Uh, yeah, thank you for the question. Yeah, am I audible?
Yes, sir, you're audible.
Am I audible?
Yes, sir, you're audible, sir. So you're audible to us. So please
Hello, am
continue.
I audible?
Yes, sir, you're audible. We can hear you.
Yeah, thank you. Yeah, thank you for the question. As such, we don't have a radiological screening that can see the lesions with the clinical examination itself. That's why we motivate a general practitioner and trained in ENT examination, and we involve all the general practitioner to screen early detection of the lesions, especially the cavity lesions like tongue cancers and buccal mucus. All these lesions are very, very easily visible, and we have to ask for all the questions as Sir was mentioning, early symptoms like dysphagia and what is the age and any non-healing ulcer, neck node, any swelling in the neck. All these lesions can be detected very early, provided we train the screeners and the general practitioners very well. And we very well know that outcome in head and neck cancer depends ultimately on the stage of the disease. The earlier the stage, the better the outcomes. And stage 1 and stage 2 have a good chance of long-term survival. And very rarely we come across stage 3 and stage 4 living for lifelong. So that's why picking up lesion is very, very important. The problem with the lesion is, for a general population, we may not expect head and neck cancers. The people who are at high risk, like using tobacco and alcohol and tobacco in any form, they generally don't come forward for screening. So they have a problem with addiction and they are not happy with doing screening. They are afraid what will happen if they tell that I have cancer like that. So those are the people who don't come for the screening, and but unfortunately, those are the people who end up with the cancer. So I do come across patients saying that one of the patients was telling that he was unable to open mouth. So what happened? How long it has been? It is there for past 1 year. He was telling. So now why you came like that? I asked. So he was telling I'm unable to have tobacco inside my mouth. So I cannot open mouth and then I'm unable to keep the tobacco inside my mouth. That is why I came here. So that much of addiction they have. So it's very pathetic. Nobody wants to diagnose early. Thinking even they have ulcer, they don't come forward and show to the healthcare practitioner. Why? Because they are very much afraid. They think that the moment they are diagnosed, it is the end of their life. It is not so. We have so many surgeons who are very well trained and they give very good outcomes, and we do have a very good outcome in radiation as well, especially in throat cancers, larynx, and oropharyngeal cancers. But even the studies say that we can decrease the mortality by 30% by doing proper screening in a high risk individual. But the high risk people are the one who are not willing to do screening, and they are not happy with screening because they are very much afraid, and they are very addicted to the tobacco usage and don't want to come up for the screen. This has to change, and the pattern has to change, and we have to focus on them mainly.
Thank you so much, sir, for your answer. Yeah. Thank you, sir, for answering that. And the kind of example you just gave us, I think that is something which is right there in people's head. They won't come up until unless they face any bigger problems. So I think that was his biggest concern, that he could not eat tobacco anymore. That's why he came up. I think that's the barrier which we want to break with this panel discussion, so that we can create as much as awareness we can and to spread awareness around signs and symptoms. Thank you for answering that. And now moving on to my next question, Dr. Vidya. So, what has been your experience? Sorry, to Dr. Karthikeyan, do you face any region-specific barriers in head and neck cancer detection, and how can be these mitigated through institutional support or policy-level interventions?
Good evening. Am I audible?
Yes, sir, you're audible.
Yeah. So, as I mentioned, there are many region-specific barriers. They do exist in, especially in India, because there is an unequal access to healthcare infrastructure. So there is a disparity mainly in urban and rural areas, mainly with respect to accessing to for the diagnosis purpose also and for the treatment purpose also. And mainly the rural areas, they lack a dedicated cancer center compared to urban centers where there are multiple centers there are. And also there is a lack of awareness and screening programs. So now in many cities where they do a health checkup, but in rural areas they don't do any health checkup. So lack of awareness is there with respect to urban and rural areas. And since there is lack of awareness, early detection is missed. So majority of the times, the rural patients they tend to present with later stages of cancer at the stage of diagnosis. And also, with many areas, they have some social stigma with respect to behavioral factors also. And and also there is a regional variance in incidence of cancer as well. So in India, there is in Northeast India, there is high chance of oral cavity cancer. Whereas in with south of India, there was HPV related cancers are more. And also resource constraints are there with limited to access for diagnosis with respect to equipments available and also surgical expertise and high-end radiation machines. So these are all not available in the rural areas. So that is my comment.
Thank you for answering that, sir. And yes, this will definitely help us to create more awareness around our listeners and audience out there. My next question is to Dr. Vidya. So, what has been your experience in identifying patient delays in seeking care, and what role can public health campaigns play in altering this?
I think, as we all are aware, that advanced diseases, especially locally advanced and advanced diseases, have poor outcomes. So I think the burning question is how fast or early can we diagnose the patients or and treat them. So the important thing, what I've seen in my experiences, why patients have a delay in seeking medical care is lack of awareness. So most patients are not aware of the symptoms of cancer, especially early symptoms. So they probably think that it is mostly related to some benign infection or sore throat or something like that. So first is lack of awareness, and then once even if somebody tells them that this could be cancer, even a family member or a friend, they usually tend to have a sense of denial. Especially this happens. This is what I've seen in mostly people who have high risk behavior, like heavy drinkers, smokers. They tend to deny that this is probably related to smoking, but not related to cancer. Though, so they dismiss the symptoms. The next thing is social stigma, because most of the head and neck cancers can cause disfigurement of the face or something like this. They tend to have, they're ashamed of the things and they don't present to the doctors very early. And then uh, having a fear, there is a wide sense of fear in the community that treatments of cancer, especially chemotherapy, radiation therapy, are very toxic. They can be very challenging. So most people also have a fear of the treatments, or the diagnosis of cancer itself can cause fear in them. So most of them do not present or seek medical care for those conditions. The other thing is socioeconomic barriers. Like most people do not have any insurance, or they, when they stay in remote villages, they may not be any access to healthcare easily. So, and again, transportation is a big problem, and then logistics, money. So many socioeconomic barriers can play, and especially sometimes family members, lack of family support is also a big part. And the one most important thing, when I travel to rural places, what I see is a lot of cultural beliefs. So most people do not tend to cross their villages. They say that there's something bad might happen to them, so they do not tend to come out of their villages even when they are told that there is a cancer or any other disease. So these are some of the important barriers, I think, or factors which influence the patients and delay them in getting the medical care. And coming to your second part of the question, the role of or the importance of public health campaigns, I think public health campaigns can have a transformative role, and they are very crucial in early detection of cancers. So I think conducting cancer camps, awareness camps, especially highlighting the importance of risk factors like smoking, alcohol, to head and neck cancers, and again making them aware of the early symptoms and signs of cancer, and then encouraging them to undergo screening, and also educating our peers and what you call dentists or primary health care rural medical practitioners who are there in the villages, and educating them about these things, I think will definitely have an impact. So I would like to quote an example. As we all know, the central government has the National Cancer Control Program, NCCP, and we see quite a lot when we go for a movies and all, they play that video messages that smoking, yes, definitely tobacco usage can cause cancer. I think that is one good example where people have really benefited out of that. They're at least aware that yes, smoking can cause so many, or tobacco usage can cause so many problems. And the other part which I have seen recently is in our state of government of Andhra Pradesh, they have introduced something called a preventive oncology OPD. So not just the tertiary cancer centers, but even the centers like the primary health centers and the community health centers, there is a dedicated day. So they every Monday in the primary health centers and even the in the community health centers and the tertiary centers, they do a cancer preventive oncology OPD is run along with the other OPDs. So people are made aware that yes, you can get, if you have any doubt, you can get yourself walk in and get screening or a medical checkup easily. So I think with once this program has been set up, I think we are seeing a lot in more cancers being diagnosed. I mean, people coming at very early stages. I've seen recently in the last 6 months, maybe very few tongue cancers, especially when they're very small on the lateral border, they come seeking for medical care. I think so. Definitely, the role of public health campaigns is very, very crucial in the early cancer care.
Definitely, so what all example you just quoted to us has definitely made an impact, and those factors which are making people, a delay in coming to doctors for the screening, and which is giving, making a delay in diagnosis for the cancer. I think those are the factors which can be worked on, and the examples you quoted, those are amazing, and I believe the ad which comes before the movie is making a great impact. It is certainly making some drop in rates of cancer detection in head and neck cancer. So thank you so much for answering that question. Moving on to my next question, Dr. Arun. So in your consultation, how do you ensure patient fully understand their diagnosis and treatment pathways, especially when emotions and fear make cloud comprehension? Because at that time, I believe they're not in a condition to understand what all the doctor is trying to explain them. They're too much emotional.
Yeah, I think so. I will just start from where we ended last time. Because one of the major issues is that people have this fear of cancer, particularly even when they go for movie, they're seeing somebody with a huge tumor suffering a lot with cancer treatment and all. So that sometimes has got a negative impact because many of our cancers may be early cancers. So they may be cured. Such a disfiguring surgery may not be needed for many of the patients. So they still equate a cancer treatment with a lot of sufferings and other things. But very small tumors can be eminently surgically corrected, and they can be cured. But then this fear has to go out. So we have to explain, and again, it depends on each person. Some people may not be educated. There are people who come with the latest Google articles and they want the latest radiation therapies and all. So it's a broad spectrum of patients who we have to deal with. So we have to understand what is their level of understanding. So we sit with them, we explain with them, and usually I send them to meet the radiation oncologist, surgical oncologist, everyone. So many of the patients may require even help of a psychologist also. So those things are important. That initially they have to come out of that fear, and you have to make them ready to undergo the cancer treatment. Because again, head and neck cancer, the treatment may be prolonged treatment. So we have to explain in detail, and if they are able to do that, and if they're educated properly, I think we'll be able to succeed.
Thank you so much, sir, for answering. And I believe education plays a very important role in this case, or any of the awareness sessions where we want to educate our public and our audience about this particular dangerous disease, so that they can take timely action. Thank you so much. My next question is to Dr. Vamshi. So, with technological advancements, which diagnostic tool do you find most impactful in aiding early detection of head and neck cancer in high volume settings?
So, so the most important tool for any doctor is still a good clinical examination. So, using your clinical examination, using your torch is probably the most important thing you need to do for head and neck cancers. Once you detect something odd, it is important to examine properly. And once you have examined and you know clinically there is a doubt of at least oral cavity cancer, then you go ahead with the further steps of management. Typically, the management and diagnosis would require what we call a biopsy. So you take out a small piece of the tissue and get it tested. It is important to counsel the patient because we have been discussing cultural issues. We have been discussing the fear of the patient. Some people are afraid to do a biopsy, saying that if you do a biopsy, it spreads. I think this is the biggest myth that, as oncologists and in public service, we need to tell. Nothing will happen if you take out a small piece for diagnosis. Once you have diagnosed, that's when we go on to do the other scanning. Usually, we do some form of imaging, that is either a CT scan or an MRI or a PET CT scan as will be needed. So that really goes tumor to tumor, institute to institute. It is important to, at the outset, establish all this with the patient. So on day one, we tell them, look, first we'll do a biopsy, next we will do a CT scan, next we will plan your treatment. Because sometimes patients come to us and they will say, oh, something is there, please start treatment today. So the treatment would need to be calibrated to each patient, and that needs some time when all the investigations are done. So that's something we need to inform the patient. This is one set of cancers which are visible to us. That's the oral cavity we keep talking about. The other type, which is inside the oral cavity, that is where you need to put a small camera, something like a scope, a small camera, look inside the mouth, try to take a biopsy from inside. Or you can look in the throat, or you can look in the vocal cords, which produce the voice. So all this requires a bit of technique. It is not very difficult. I mean, a reasonably trained doctor can do it. So again, the message to the patient, however, is that it's going to take 2 3 days. Bear with us. Get your test done properly, and so that we can plan a full treatment. So that is the message that we need to give to the patients, and that's the message we need to pass on. The diagnosis is not instantaneous. There are some tests which are done, and based on that, we can offer a best treatment. As some of my earlier speakers alluded to, we do have something called a joint clinic or a multidisciplinary tumor board, wherein every patient would be seen by 2 3 doctors. That also gives confidence to the patient that multiple people are seeing and multiple people are going to help in the diagnosis and treatment. So overall, it's a process which needs to be explained in detail to the patient so that they understand what's happening. So that's what I would like to say on this.
Sir, I think there is connection issue with the Simran. She is joining in a bit. Yeah.
Okay, so I think the other message, I think I would, maybe some of the other panelists can chip in with their experience of any other thing during diagnosis by the time Simran joins us. Dr. Ravi, any thoughts from your
Uh,
side?
just, just, just give me a Yes, yes. I'm really sorry. So there was some technical error. I was logged out. Yeah, thank you so much, Dr. Vamshi, for giving us that explanation. And I believe that the way you explained us how this multidisciplinary approach is required, so that the patient understand the diagnosis or the treatment better, and they also build the trust among the doctors who are treating them. I think that's very important, so that he can just be just. Rely on them and trust the process which he or she will be going through. So thank you so much for explaining that to us. Now my next question is to Dr. Ravi. So what are the best practices you have implemented for ensuring smoother follow-ups and continuity of care for head and neck cancer survivors? Dr. Ravi, you're on mute.
Yeah, thank you. As Dr. Vamshi was telling, and I'll continue with that step. So it is a multidisciplinary management which mainly, not only in head and neck cancer, for all cancer, it is a multidisciplinary management where it involves from an medico-social worker to a counselor. Then comes a doctor's role, getting a diagnosis, biopsy. Then again, we will sit and discuss with the patient, family, collectively and individually. And then once the plan has been explained about the treatment plan, because whenever we are planning cancer treatment, it is not just about a week, 10 days. Usually it will be for about 3 months to 6 months. It varies on what type sorry, what type of treatment plan we have planned. Usually once we chart out the treatment plan and it has carried out, again the team is very important. First, we will ask individually with the family members and the patient what doubts they have, what fear they have. We'll clarify them. Usually in head malignancies, the treatment part will be surgery, then chemotherapy and radiotherapy, and in some cases, in advanced cases, immunotherapy. So, whenever we plan a treatment, it is not only the patient's part; it's mainly the family which needs to be handled. And even in the follow-up, also it is the same. It is not only the patient; it is the family and caregivers that is very important. So once we take the confidence of the caregivers and tell them that, look, this is the treatment, and once the treatment is over, this will be the follow-up plan. Once in 2 3 months, we will call them. We will examine and see for any recurrence or any side effects of our treatment. We will ask what all social problems they face, any daily activity issues they have. So we will try to sort it out. Again, in our team, we have psychological counselors. They play a very important role because whenever we treat a cancer, there will be a lot of emotions, depressions, which we need to handle. A social medico-social worker will be there. Even on follow-up, we take their help and see that whatever needs to be done to get adjusted a patient and family in the society, that needs to be taken care. And again, the referring doctors or the general physicians or the dentists, they are also very important. They are also main pillars in our team. Once our treatment has been done, we will involve them. We do discuss with them that the treatment plan is over. If any issues are there, they will come to us. So it's again good teamwork involving not only the clinicians, the social workers, the referring physician, and main important, the family members. So once we ensure that all these things are taken care, then the follow-up will run very smooth. Otherwise, what will happen because of the fear or some side effects, the patient won't follow up, and the curable malignancies will not be cured. So that initial discussion, it doesn't get over in 1 or 2 visits. Usually, it will take multiple visits, and we should take the family and patients in confidence, and then the treatment and follow-up will be very smooth. Thank you.
Thank you so much, Dr. Ravi. And we know that how holistically our doctors and healthcare givers are working to treat the patient in each and every direction. Thank you so much for answering that. My next question is to Dr. Sivasubramaniam. So, are you seeing any efforts at the institutional level to implement structured screening protocols for high risk population, and what impact has that had on early detection? So, you're on mute. Dr. Siva, you're on mute. Yeah.
Yeah, sorry. Yeah, sorry. Yeah, in Tamil Nadu government has made a master health checkup in most of the medical colleges and hospitals. So it has included a ENT evaluation as a part of a screening program in the master health checkup, where ENT medical doctors give their opinion and they completely examine. They do scopies and they ask for signs and symptoms and they evaluate them thoroughly. And they do scopies whenever it is indicated, and then they come up with any diagnosis, and if they are suspicious anything, they are advised to do a biopsy also, and thereby we are able to pick up yearly lesions also. The problem is again the high risk people are very much afraid of coming to the master health checkup and doing ENT evaluation, but this has made a very good impact in the yearly picking of diagnosis. And this health checkup, it's come in a very good package, very less price for the poor patients. It costs only 2,000 or 3,000 rupees. It has a various number of tests, and it has included almost all the specialties like cardiologist, ENT, and this one pulmonologist, and it's very useful for the uh, public sector. And coming to the private corporate hospitals, and it also has a checkup, and ENT evaluation is a part of this master health checkup. And especially for high risk people, we do ask all the signs and symptoms, and then do a complete examination and also scopies whenever necessary. And this is how we do this evaluation, and we are able to pick up yearly lesions. And the problem again here, the coming up of patients to check up, the high risk people, they are not at all keen on doing this, thinking that what will happen if I am diagnosed with something, what will happen, there is the end of life, I will be forced to stop tobacco, I will be scolded for using tobacco. So all those things prohibit them from coming up for screening. But we have to further motivate and subject them for screening. And we have almost all the health checkup incorporating ENT evaluation and ENT specialists as a part of the program, and thereby picking up yearly lesions. We do come across yearly tongue cancers, yearly buccal mucosa cancers, where previously we only see stage 3 and stage 4 only. Because of this problem, they are addicted, they are not in a position to accept diagnosis, they are not in a position to stop the tobacco usage, and not at all willing to do any treatment also. But this scenario is slowly changing and people are able to pick up early. And there are scenarios, the general public without any risk factors, who are developing head and neck cancers, like females developing no history, nothing, no tobacco usage, no abnormal sexual habits, and no sharp tooth, and no other history, but still they have some oral ulcers. So those are the people who are very much beneficial by this screening program. Of course, the high risk people will be benefited more, but the challenge is bringing them up for a screening program.
Thank you so much, Dr. Sivasubramaniam, for explaining that. And it's good to know that how the state governments and the institutions are working to this. At least, even if the women who are not diagnosed with the cancer, they are ruled out of not getting diagnosed. But like you said, this will help us to reduce the cancer rates, and people are coming for the screening. I think that is one of the biggest achievement, and that's how we lead to a better future. So thank you so much for answering. My next question is Dr. Karthikeyan. So, do you face any region-specific barrier in head and neck cancer detection, and how can these be mitigated through institutional support or policy-level intervention?
Okay,
So,
as I mentioned earlier, that region-specific barriers because of unequal access to healthcare infrastructure, which I mentioned earlier. That is disparities between the urban and rural with respect to diagnosis and treatment. So this AI, I think it can help with respect to diagnosing the tumors at an earlier stage. In rural areas where there are no healthcare expertise who are available, This AI-driven tools can help in detecting these tumors at an early stage, and this can also help in the patient to get access to healthcare at a very early stage. So in this aspect, so there are multiple AI platforms now available. So where we can ask the patient to upload the images uh, or even the reports. So where they give some uh, the diagnosis also and about the stage. So in this aspect, I feel like AI has transformed the healthcare, and with respect to cancer, it is definitely it uh, is indeed changing the landscape of cancer.
Thank you so much, Dr. Karthikeyan, for answering that. My next question is Dr. Vidya Sagar. So, from your perspective, how do family and social support system affect treatment adherence and patient morale? And what models have worked well in your institution?
I think family support and other social systems play a very critical role in the, especially in Indian setup, because mostly it is the family members who are always involved in making the decisions, and they are the ones who actually bring the patient, take care of the logistics, the even the financial part. So I think it is very important to involve the family, especially for treatment adherence. And most of the times, what happens is there'll be one family person in the family who is actually more literate than the others, even health wise, not just normally. So, especially trying to explain him what are we trying to do, what are we trying to achieve, and what is the importance of adherence to the treatment and its impact on the outcomes. I think it plays a great role, and commonly boosting the morale. I think just having the family members there itself can boost the morale of anybody. So I think, and we have seen time and again that patients who are isolated or weaker economic households that who don't have a strong family or a social support, I think in those patients we see either a treatment refusal or there will be a treatment discontinuation, early discontinuation. So I think it's equally important for the family to bring in the family in involving them in the patient care. And coming to our hospitals, I would say the models which we have tried to adapt, which can make an impact on the patient's adherence and the morale, is we tend to usually have the patients have a local language counselors. Being not part of the North Andhra, we have a lot of patients who come from the neighboring states, especially Orissa, where language barrier is a huge problem. So we have in our hospital local language counselors which communicate to them as to what we are trying to convey, and then because of that most people understand that what is the doctor trying to do to the patient. The second thing is we have financial counseling support systems. So we have a wing for that, where once the patient is sent to them, they explain about them about the insurance or even the cash or whatever it is. So whatever help from the institute side can be given to them. So that is being provided. And the other important thing is patient communication. I think communication is the key for any patient good outcomes. So what we try to do is provide the patient with the patient education support material. So like we have, most of us, we have guidelines which are guided towards the doctors, especially for the doctors, but we have certain guidelines for the patients which are given by international institutions like NCCN. So what we try to do is try to provide them the material which is written in the simple language, so that the patients can understand what about the disease, the staging, the workup, even the treatment options, what are the complications that can occur. So it equips them with more information, and then they always come up with questions which actually help them to get a clarity. So they are not afraid of the complications. If something happens, they always are ready to reach out to us. The other thing is, especially in head and neck cancers, nutrition is a very, very important thing. Most people will have problems in intake of food. So we have a dietitian and their department, which often visits them in the patient while they're in the hospital, and they give them bedside advice as to dietary advice, what is available to them easily depending on their financial status also. So I think these support systems, these are the things, some of the things which we have done. And the one more important thing what we have done is we conduct regularly outreach clinics. That even myself, I go out weekly once to the rural areas where the patients commonly come to us. So what happens is, even if the patient is at home for some reason in between the treatment, he can always reach out to us at his hometown. And so that, because we are easily accessible to them, patients have that sense of security, that yes, the doctor can be is easily accessible to us. So that again helps them to overcome challenges, clarify their doubts or whatever it is. So these are some of the few things which we are doing at our institute. And one more thing is, when the patients are sitting in the OPD, like with the waiting hall or something, we have monitors or televisions, where we have made short videos about each and individual cancers and the common things, what the like the symptoms, and the education material, like be it about the diagnosis, screening, and the treatment complications, and how do we go about them. So patients usually sit there and look at them, and they try to listen to them. So they are always being given information which they actually need. So even if the patient is not actively asking, we are providing them the required information, and so that they can strictly adhere to the protocol and have a better outcome.
Thank you so much, Dr. Vidyasagar, for explaining that, because this tells us the importance of educating the entire family whose person family member has come up for the treatment, and as well as the patient as well, because this gives them the trust, this gives them the better knowledge how this is going to work, and the to understand the better understand this complete process. So thank you so much for that. Now we'll be moving forward to our next segment, that is a little fun and more engaging, interactive. So this is we have some myths versus fact about head and neck cancer. So I'll start my first with Dr. Arun. So the myth is head and neck cancer only affects the tobacco users. What would you say on this?
So I think I had already touched upon that when in the first question, because a lot of cancers we are seeing in non-smokers also, particularly in the younger age group and all, where we feel that the HPV virus infection may be a reason for that. And again, some trials have told that reduced intake of vegetables and all can have an impact on increasing incidence. So it is not just tobacco users. So that is why we have to be careful. If there is something in the mouth, that any sore which is not healing, any bleeding which is not stopping, any pain which is persistent. So whatever be the age and whatever be the risk factor, if these things are there, one has to be suspicious, and they have to consult a doctor. So I think that is a big myth which has to change, because sometimes we have seen that in tobacco use and all, they may just get a thickening of the whole what is that, the ginger, whole cheek and all. So there may not be even a swelling. So particularly those pan gutka users and all, it may be just a thickening there, and it is very difficult to treat such cancers also. So any undue thing which comes up, irrespective of the habits and all those things, they have to undergo further tests.
Thank you so much, Dr. Arun. And yes, tobacco is a major risk factor. Non-smokers can also develop these cancers due to HPV or other causes, and like Dr. Arun also explained. My next myth is to Dr. Vamshi. Sir, if there is no pain, it can't be cancer. Is it a myth or a fact?
It's a myth. You can have cancer without pain, especially in the early stages, and depending on the location. So, depending on where the cancer is, it can cause, it may just present with unknown side effects. For example, I was talking about how hoarseness of voice can be one of the earliest symptoms of throat cancer. A vocal cord cancer or a throat cancer, they will not have pain. They will simply have hoarseness. They'll have a change in the voice. Sometimes people will present with a lump in the neck, a neck node. That is not painful. Similarly, even small ulcers can be hard and firm on the tongue and they will not be painful. I think people need to be educated that pain is actually one of the last symptoms of cancer. And the presence of pain indicates that the cancer is advanced. If the aim, or as we have been talking till now, everyone wants to diagnose cancer early because can cure it at that point of time. So waiting for pain for cancer is completely a big myth. Anything which is abnormal, we should investigate, and pain is not the only symptom of that. So I'm happy you brought out this myth, and hopefully the message will go out that it is not there.
Definitely, sir, and rightly said, many early stage head and neck cancers are painless and normally go unnoticed. So, yes, moving on to my next with Dr. Ravi. So, the thing myth is only older people get head and neck cancer. Is it a myth or a fact?
Yeah, again, it is a myth. Nowadays, what has happened is we see a lot of youngsters getting malignancies. And as we have discussed in the previous discussion, it is not only tobacco related, there are various other factors. HPV is one another important risk factor. And many of the time, say 30-40% of the time, there won't be any reasons only. So we have to find out. Even the families ask to us that what is the reason that in young age we have got a malignancies. There won't be any family history. Is a non-alcoholic, no tobacco history, uh, and very strict in their health consciousness and all. So definitely, malignancies, though to a certain extent they are common in older people, but age is not a bar. We have seen head and neck malignancies even younger age, starting from the age of say 20, 22 and all, and not hereditary. So definitely the message should go that age is not a factor. So any person having warning signs, especially in head and neck, what we have discussed, a lump which is not going or an ulcer which is not healing, uh, irrespective of whether they have any habits or not, they should get examined irrespective of the age.
Thank you, sir, for answering that. My next statement is to Dr. Sivasubramaniam. So, head and neck cancer is always visible externally. Is it a myth or a fact? So, you're on mute.
Yeah, we have definitely, because we do have hidden areas, and those are the things which we don't see visually. For example, oropharyngeal, hypopharynx, as well as this laryngeal cancers are internally seen, and the early symptom will be, it will be symptom only. We have to suspect, for example, voice change. Just a hoarseness of voice will be a earliest symptom of glottic cancer. So people won't have any visible swelling, no, nothing. Only voice change, and we have to be very cautious and keen, and suspect those things, and they have to examine those things. And hypopharyngeal cancer will not be visible externally, and the early symptom will be just dysphagia, difficulty in swallowing, not even pain, just a small discomfort, and just drooling of saliva. All those things are all hidden areas we don't see generally.
Thank you, sir, for explaining that. And yes, these cancer can often develop in hidden areas like throat or sinus and may not be visible, but that does not mean that you don't have to go to a doctor. Go to a doctor as early as possible to get it screened. My next statement is to Dr. Karthikeyan. So, surgery is the only treatment option to treat. Is it myth or a fact?
No, surgery is not the only treatment option. So, like, it depends on the stage again. So, if it's an early stage oral cavity cancer, the primary treatment would be surgery. Or if the disease is in a little bit advanced stage, stage 3, stage 4, so patient will require combined modality treatment. So, combined modality treatment is patient will undergo surgery, and also patient will undergo radiotherapy and chemotherapy. So surgery is not the only treatment option as far as head and neck cancer is concerned.
Thank you so much for clearing that myth, sir. And yes, treatment may involve surgery, radiation, chemotherapy, or a combination tailored for the patient. So that is not true. My last myth is to Dr. Vidya Sagar. So once treated, head and neck cancer can never come back. Is it myth or a fact?
That is completely a myth. Not only it's good for the thing for the head and neck cancer, for any cancer, recurrence can be there. So mostly head and neck cancers recur either in the form of local recurrence, like the site where it was earlier, or they can present somewhere else in the body. Especially head and neck cancers tend to spread to the lungs. So it is equally important for the patient, once the treatment is completed, to come for regular follow-ups, because why the follow-up is needed is, if the cancer comes back, we want to pick it up at a very early stage. Like, the disease burden has to be very small. Only then the patient is asymptomatic, and the patient can tolerate again the recurrence treatment well, and there can be again a good outcome. If the patients do not tend to come for follow-up, they may again come back with advanced symptoms or extensive disease burden, which can again lead to a very poor general condition of the patient, and the patient may not be tolerating, or may not be able to tolerate any of the existing therapies, be it chemotherapy, immunotherapy, or whatever it is, or even for localized diseases, again a re-irradiation or a surgery, salvage surgery. So all the patients should understand the importance of follow-up even once the primary treatment is completed. So usually we do tend to follow up or advise the patients to come up every 3 months for the first 2 years, and post 2 years we again ask them to come once in every 6 months, and post probably after 4 years every once in a year. However, this is a generalized approach. Again, depending on the individual patient, the risk factors or the initial extent of the disease for what he was treated or he or she was treated, the doctor consulting or the treating doctor individualizes the follow-up period of the patient, and also the investigations. It's not like every follow-up or visit we do tend to investigate them. Mainly, as Vamshi sir said, it's the physical examination is very, very important. So attending the patient, asking them whether they have any new symptoms which can be related or may not be related to the cancer. So it's equally important for the treating doctor to explain the importance of the patient, and this where the family comes in. And also, as I said, going to having an outreach clinic. So the doctor himself is being available to the patients at their own hometown at least once in a while. It may not be regular, but that is when the patients can also come for regular follow-ups. I think that will help the patient a lot.
Thank you, sir. And rightly said, yes, reoccurrence is possible, but making regular follow-up care is very important. So, with this, I would like to conclude this panel discussion and would like to thank all my panelists present here for sharing their insights, experiences, and their views on this critical topic, and explaining us each and every process involved in this complicated disease, and how we can win against this with regular screening, rightly treatment, and with all the follow-ups. So thank you so much for coming to the platform, giving your advice, because it means a lot to educate and aware our audience out there. Thank you so much.
Thank you. Good evening.
Thank you.
Thank you. Bye. Bye.
Thank you.
Thank
Thank
you.
you. Bye.